Today we are going to discuss about cephalometrics in orthodontics. Cephalometrics is one of the essential diagnostic tools in orthodontics. Let us look into what is the meaning of cephalometrics. Cephalo means head and metrics means measurement. So the term cephalometrics indicate measurements that are made on the head. When we see the definition of cephalometry, it's nothing but analysis and interpretation of different features or different measurements of the head that are made on the standardized radiographs obtained of craniofacial bones. So the cephalometry is analysis and interpretation of different standardized radiographs taken on craniofacial bones. The cephalometrics was first introduced by Hawley and Hofrath and Broadbent in the year 1931 individually. So the technique was developed by these persons individually, one in Germany and another one in USA. A cephalogram, as you know, it's nothing but a radiograph taken on the head. It represents various craniofacial bones that are present. When coming to the technical aspect, a cephalogram is taken by means of equipment called as cephalostat along with the X-ray production unit. A cephalostat consists of a head positioner to position the head normally. Usually, whenever we take a lateral cephalogram, a head is positioned such that the patient sees at the distant object at the eye level. We call it as a natural head position. And the Frankfurt horizontal plane should be oriented parallel to the floor, and the head should be symmetrical. It should not be bent into one side or the other. It should be straight, and the patient should be looking at the distant object at eye level with FH plane parallel to the floor. Now, the cephalostat has ear rods that goes into the external auditory meatus of the patient and an orbital pointer that points along the lower orbital margin. And the teeth should be in a centric occlusion and the lips should be in a relaxed position. So a lateral cephalogram is taken by positioning the head in this manner in the cephalostat, and the X-ray production unit is used to project the X-rays onto the head of the patient, and the image will be recorded onto the cassette that is placed on the side of the patient. This is the setup of lateral cephalogram image acquisition. It consists of a X-ray source, and the patient's head is positioned between the X-ray source and the cassette which carries a lateral cephalometric film, and the distance between the X-ray source to the patient and the patient to the film, that is target film distance and target film distance as well as target and X-ray source distance are standardized. The distance between the X-ray source and the patient should be 60 inches, and the distance between patient mid-sagittal plane and the film holder or the cassette should be 15 inches. These measurements are standardized because, as we know, we need to take repeated lateral cephalograms for the same patient during the course of orthodontic treatment. If these measurements are not standardized, we might have a lateral cephalogram of pre-treatment of one dimension, whereas the lateral cephalogram at the mid-treatment and post-treatment will be of some other dimensions. So in order to reproduce the image same as taken before, we need to standardize these dimensions between we have to standardize the target film distance and the target source distance. So this is the setup for taking a lateral cephalogram. Okay. Now let us look into the uses of lateral cephalograms. So the lateral cephalograms are mainly used to assess different components of the craniofacial skeleton, whether the different components of the craniofacial skeleton are normally related or there is any deviation in the normal relationship. So assessment of facial and dentoskeletal relationships is one of the important uses of lateral cephalogram. The next use is to study the growth and growth patterns in an individual over a period of time. Here we take a lateral cephalogram of a patient at one point of time, and the same lateral cephalogram will be repeated on the same patient with same parameters after certain period of time. Now, comparison of the lateral cephalogram between 2 points of time will give the type of growth changes that has occurred in that patient and the pattern of growth that has occurred in that patient. So, to study the growth of an individual with respect to the growth increments as well as growth pattern, we use lateral cephalogram. The next important use of lateral cephalogram is to plan the orthodontic treatment. So there is something called as visualized treatment objective. That means when we have a patient of certain dentoskeletofacial characteristics, we will use a lateral cephalogram to assess the underlying mal relationship, and we will form a blueprint for that patient that his dentition should be like this at the end of the treatment. Okay, his teeth angulation should be like this, or his teeth inclination should be like this. So we will presume the required changes in the patient, and that can be visualized. That means if the teeth are positioned in their presumed position, we can trace out the appearance of the patient by using the lateral cephalogram. That means this is called as production. These are called as production tracings. So the lateral cephalograms are useful in the planning orthodontic treatment as well as production tracings. And the next important use is evaluation of post-treatment changes. Once the treatment has completed, we can compare the pre-treatment lateral cephalogram with the post-treatment, and we can see how the changes has occurred with our orthodontic treatment. Has the goals that we have established before the treatment accomplished at the end of the treatment or not can also be checked by means of using lateral cephalograms. Now, lateral cephalograms are also used for research purposes in long-term follow-up studies. As I told you before, when we carry out growth studies, lateral cephalograms are of great importance because we can assess the growth increments as well as growth pattern of the patient over a period of time. So they are very much useful in long-term growth studies. So these are some of the important uses of lateral cephalogram. Now, as we know, cephalogram is nothing but a study of measurements made on the head. Now, a cephalogram can be obtained from the lateral view as well as a posterior anterior view. Accordingly, we have two types of cephalograms. One is lateral cephalogram as well as the second one is frontal cephalogram. Lateral cephalogram gives you two-dimensional relationships in anteroposterior plane as well as vertical plane, whereas frontal cephalogram will give you measurements or a relationship in the vertical plane and transverse plane. That means any case of facial asymmetries can be evaluated and studied by means of using frontal cephalogram, whereas any cases of vertical as well as sagittal discrepancies can be better studied by use of lateral cephalograms. Usually for every patient we will be prescribing lateral cephalogram, and posterior anterior cephalogram is reserved for only those patients who present with gross facial asymmetries. Okay, our discussion will be mainly focused on the lateral cephalogram. This is a lateral cephalogram and this is a frontal cephalogram. We call it as a posterior anterior cephalogram also, which gives you any kind of facial asymmetries that are present. Now, the next important discussion is cephalometric landmarks. We know how to obtain a lateral cephalogram. Now, once we have obtained a lateral cephalogram, I said they are useful in analyzing the relationships between different components of the craniofacial skeleton. In order to analyze these relationships, we need to have some reference points, isn't it? These reference points are called as cephalometric landmarks. Cephalometric landmarks can be classified into anatomical as well as derived, and they can be further classified into unilateral or bilateral. Anatomical landmarks are those points which are actual anatomical representations of the structures in the craniofacial skeleton, whereas derived landmarks are those landmarks which are not actually represented anatomically, rather they are obtained by intersection of some planes and bony structures. Okay, so anatomical landmarks are true representations of anatomical structures, whereas derived landmarks are not anatomically present, rather they are identified or produced by means of intersection of different planes or by means of intersection of different bony structures in the craniofacial skeleton. Now, what are the unilateral landmarks? These are nothing but all the landmarks which are present along the midline are unilateral landmarks, whereas the landmarks present on either side of the midline are called as bilateral landmarks. Now, let us look into these landmarks one by one. Let us look into the anatomical landmarks. One is sella turcica. It is nothing but midpoint of the pituitary fossa or hypophysis cerebri. This is called as sella turcica. The next one is orbital. Sella turcica is a unilateral landmark, whereas orbital is a bilateral landmark. Orbital is nothing but inferiormost point on the infraorbital ring or inferior margin of the bony orbit. This is called as orbital. So, sella turcica is a midline structure, unilateral landmark, whereas orbital is a bilateral landmark as it is present on either side of the midline. The anteriormost point on the frontonasal suture, as you can appreciate from the image, is called as nasion. Nasion marks the anterior limit of anterior cranial base. The point on the anterior margin of the foramen magnum is called as basion, whereas the point on the posterior postcondylar notch of the occipital condyles is called as Bolton's point. Okay. Antermost point on the frontonasal suture is nasion. Point on the anterior inferior margin of the foramen magnum is called as basion, whereas a point on the postcondylar notch of occipital condyles is called as Bolton's point. Anteriormost point on the hard palate is called as anterior nasal spine, whereas posteriormost point on the hard palate is called as PNS or posterior nasal spine. Usually it is very difficult to locate the posterior nasal spine. You can see the pterygomaxillary fissure points towards the PNS. So once you can identify the teardrop shaped pterygomaxillary fissure, and as it points towards the posterior nasal spine, it will be easy for you to trace the posterior nasal spine once you have observed on the lateral cephalogram the pterygomaxillary fissure. Now, point A and point B. Point A is nothing but deepest point on the concavity between anterior nasal spine and superior procyon or supradental. Deepest point on the concavity between anterior nasal spine and superior procyon is called as point A. Point A marks the anterior limit of skeletal maxilla. Point B is the deepest point in the concavity between infradental and pogonium. Okay, this marks the anterior limit of bony mandible. Pogonium is the anteriormost point on the bony chin, whereas menton is the inferiormost point on the bony chin. Gonion is a point at the junction of ramus and body of the mandible. That is, it is a point on the angle of the mandible and it is a bilateral structure. Whereas gnathion is the antero-inferiormost point on the bony mandible or bony chin. This is a midline structure and it is a unilateral landmark. Usually, gnathion is present between pogonion and menton, and it is the antero-inferiormost point on the bony mandible. What is porion? It is nothing but a point on the superior aspect of the external auditory canal or external auditory meatus is called as porion. Whereas machine porion is nothing but, as I told you, a cephalostat has a ear rod which goes into the external auditory meatus. These ear rods are represented on the radiograph as a very well-defined radio-opaque circular portions, circular things. So the superiormost point on these well-defined circular radio-opaque representation of the ear rod is called as machine porion. Usually for cephalometric analysis, we will consider anatomic porion and not the machine porion, because there might be a discrepancy of about 10 mm between the machine porion and anatomic porion. It is always very much difficult to identify the anatomic porion. Usually we take in cephalograms where we are not able to clearly identify anatomic porion, we will usually take the anatomic porion at the level of the head of the condyle. Usually these both lie at the same plane. Okay. Next, condylion. It's nothing but superior and superiormost point on the condyle, bony condyle or mandibular condyle is called as condylion. Condylion is also in turn a bilateral landmark because we have the left condyle as well as right condyle. Now, the next important landmark is articular. Articular is nothing but it's a derived landmark. It is not anatomically present. If you look into the lateral cephalogram clearly, there is an intersection of the sphenoid bone with the neck of the condyle. This point of intersection of the sphenoid bone and the neck of the condyle is taken as articular, and it is a derived point. The next important landmark is glabella. Glabella is nothing but a soft tissue landmark present as most prominent point on the forehead. Pterygomaxillary feature is nothing but a teardrop shaped structure on the lateral cephalogram. It marks the posterior limit of the maxilla. Usually on this teardrop shaped structure, we take pterygomaxillary point at a 11 o'clock position. Subnasal. So a soft tissue landmark again at the junction of the upper lip and columella of the nose. Whereas superior procyon is a landmark, bony landmark. It's nothing but anterior and inferiormost point on the alveolus in the midline between two maxillary central incisors. This is called as superior procyon or supradental. Similarly, we have the inferior procyon or infradental, which is the anterior and superiormost point on the alveolar bone in the midline between two mandibular central incisors. So the inferior procyon or infradental is the superior and anteriormost point on the alveolar bone in the midline between two mandibular central incisors. Okay. Those were the important anatomical landmarks which we should be familiar with in order to carry out basic important clinical cephalometric analysis. Okay. It's not just sufficient to have different anatomical landmarks. We also need to have some reference planes in relation to which we can compare different craniofacial structures both anteroposteriorly, vertically or transversely, whatever it is. So we should have some reference plane. Let us look into different reference planes that are available to compare various components of the craniofacial skeleton. They include horizontal as well as vertical reference planes. Let us first look into horizontal reference planes. This is nothing but the first and foremost important horizontal reference plane is Frankfurt horizontal plane. It is the plane formed by joining porion with orbital. The next important reference plane is Cephalometrics or SN plane. This is anterior cranial base. So Cephalometrics marks the anterior cranial base. Usually we take these reference planes, either FH plane or SN plane, on different in different analysis as reference planes. That means standardized reference planes. The next important horizontal reference plane is ANS PNS plane or palatal plane, which marks the plane of hard palate. The mandibular plane. Different authors consider mandibular plane in different methods. According to Steiner's, gonion gnathion is the mandibular plane. According to Tweed's, a tangent drawn to the lower border of the mandibular body is called as mandibular plane. Whereas according to Downs, it is the plane formed by joining gonion on menton that forms the mandibular plane. That means we should keep this in mind when we are going with specific analysis. For example, if we go for Downs analysis, we should take the mandibular plane as proposed by Downs. if you are going for Steiner's analysis, we should go with the mandibular plane proposed by Steiner's as a mandibular plane. Similarly, with the Tweed's analysis, we should go with tangent to the lower border of the mandible as a mandibular plane. Okay, this you should keep in mind. The occlusal plane. It is the plane formed along the intercuspation of the molars and premolars. No matter whether it crosses through half of the crown of the maxillary incisor or half of the crown of the mandibular incisor, there is no issue. But it should pass through the intercuspation of molars and premolars. This is considered as occlusal plane. Bolton's plane is the plane formed by joining the Bolton's point with the nasion. Basion-nasion is the plane formed by joining the basion with the nasion. Basion-nasion plane marks the cranial base, the length of the cranial base, whereas sella-nasion marks the length of the anterior cranial base. Here, basion-nasion marks the length of the entire cranial base. Those were horizontal reference planes. Now coming to the vertical reference planes, we have a APOG plane. We call it as APOG plane or AP plane. It's nothing but a plane formed by joining anterior limit of the maxilla with the pogonion or point A and pogonion. Facial plane. It's nothing but a plane formed by joining the nasion with pogonion. This is called as facial plane. Now E plane or aesthetic plane according to Ricketts. This is nothing but the vertical plane formed by joining the antermost point on the tip of the nose with the antermost point on the soft tissue chin. Usually we will see a relationship between the lips and the E plane to assess the protrusiveness of the lips. The next important vertical plane is the facial axis. It is formed by joining the PT point or pterygomaxillary point with the gnathion. This is facial axis or growth axis. So those were the important horizontal and vertical reference planes that are used in a routine cephalometric analysis. Now we know different cephalometric landmarks and reference planes. Let us go into the cephalometric analysis, which is the important part of cephalometrics. Now, what are we trying to achieve by various cephalometric analysis? The main purpose of cephalometric analysis is to relate maxilla, the skeletal maxilla to the anterior cranial base, the skeletal mandible to the anterior cranial base, maxilla relationship to the mandible and vice versa, relationship of maxillary dentition to the maxillary skeletal base, mandibular dentition to the mandibular skeletal base, and the relationship between maxillary and mandibular dentition to each other. So these are the things which are going to be accomplished by cephalometric analysis, both in the anteroposterior as well as vertical planes of space. Various authors have proposed various cephalometric analysis. To name some, they include Steiner's analysis, Downs analysis, Ricketts analysis, McNamara analysis, Tweed's analysis, Cox analysis or Burstone analysis, which we do for cephalometric, orthodontic surgeries, and Holdaway soft tissue analysis, Arnett's and Bergman's analysis. So these are the n number of lateral cephalometric analysis that have been proposed by various authors. Apart from lateral cephalometric analysis, as I already told you that we are also having another kind of cephalogram called as frontal cephalogram to assess the facial asymmetry. Now, to name some, Ricketts PA analysis or Ricketts posterior anterior analysis and Grumman's analysis are the important analysis that we carry out on frontal cephalogram to assess any kind of facial asymmetry. Okay, so these are different analysis proposed by different authors. As I told you, our discussion in the present class is exclusively limited to analysis of lateral cephalogram, and that too we are not going to discuss all this analysis. Rather, we are going to discuss the main basic analysis which are necessary at this stage of understanding. Those include Downs analysis, Steiner's analysis, Tweed's analysis and Wits appraisal. Let us look into this analysis one by one. Number one is Downs analysis. So the first proposed analysis was Downs analysis. It has 10 parameters, 5 skeletal and 5 dental parameters. Coming to the skeletal parameters first, the first parameter is the facial angle. It's nothing but the angle between FH plane and NPOG or facial plane. The average angle is 87.8 degrees. This angle relates the mandible to the upper face. If the angle is more than 87.8 degree, it indicates that the mandible is prognathic. Whereas if the angle is less than 87.8 degree, it indicates the mandible is retrognathic. This is the importance of facial angle. The next is angle of convexity. Here we draw a line from nasion to point A and from point A to pogonion. If both the lines fall in the same plane, then the face is said to be ideal according to Downs. The average angle of convexity is 0 degree. If the angle of convexity is more than 0 degree, then it is represented as positive angle. As you see in the first part of the first image of this slide, there is at the left extreme of this slide, you can see the image where the angle of convexity is 10 degree. It indicates that the face is convex, probably due to retrognathic mandible or prognathic maxilla, whatever it might be. If the same angle of convexity is negative, that indicates the patient is having a concave profile, or it might be due to retrognathic maxilla or prognathic mandible or a combination of both. That means angle of convexity is that parameter which indicate whether the patient has a convex face, an orthognathic face, or a concave face. So whenever a patient has a convex profile, then the angle of convexity will be positive, whereas when a patient has a concave profile, then the mandible, the angle will be having a negative value. This is called as angle of convexity. Now, the next angle is AB plane angle. Here we have a NPOG line and we draw a line along point A to point B. The average angle is minus 4.6 degrees. Remember, don't get confused between angle of convexity and AB plane angle. Both the angle indicates the same parameter, whether the face is convex or concave. But if the face is convex, the angle is positive for facial plane angle, positive for angle of convexity, whereas if the face is convex, the angle is negative in the AB plane angle. That means the annotations differs. Positive value for convexity in case of angle of convexity, whereas negative value for convexity in case of AB plane angle. So the average AB plane angle is minus 4.6 degrees. If the angle is more negative, that indicates the face is more convex. If the angle is more positive, or it is say below 4.6 degrees, like minus 4, minus 3, like that, then the face can be taken as more towards orthognathic profile or more towards concavity, depending upon the lower limit. The range is 0 to minus 9 degree. So any value beyond minus 9 degree indicate that the face is more convex. Any value below 0 degree, like 0 degree, minus 1, minus 2, indicates the face is towards more of orthognathic type or more of concave type. The next angle of skeletal parameter is the mandibular plane angle. As I told you, according to Downs, the mandibular plane is the line connecting the gonion on menton. So the mandibular plane angle is the angle between Frankfurt's horizontal plane and mandibular plane. The average angle is 21.9 degree. Any value above 21.9 degree indicates that the mandible is rotating in a downward and backward direction, which is indicated as the patient has a vertical growth pattern, or the mandible is rotating in a clockwise direction, leading to increased lower anterior facial height. Whereas if the mandibular plane angle is less than 21.9 degree, that indicates the mandible is rotating in a counterclockwise direction, leading to a reduced lower anterior facial height and a horizontal growth pattern. The next important parameter of the Downs analysis is y-axis or growth axis. It's nothing but the angle between Frankfurt's horizontal plane and facial axis. The average value is 59.4 degree. So the facial axis also indicates in turn a growth pattern, whether it's a horizontal or a vertical growth pattern. If the angle is greater than 59.4 degree, it indicates a vertical growth axis, whereas the angle less than 59.4 degree indicates a horizontal growth axis. So you have to correlate the mandibular plane with the y-axis or growth axis in order to assess whether a patient is having a increased development of a lower face or decreased development of a lower face, or increased vertical growth pattern or a more of horizontal growth pattern. So these are the conclusions that can be drawn by these two angles. So these are the 5 skeletal parameters according to Downs analysis. Now let us look into the dental parameters. The first parameter is cant of occlusal plane. We draw a line through the intercuspation of the buccal cusps of molars and premolars. This is called as occlusal plane, and we draw a line that is FH plane. The angle between FH plane and occlusal plane is taken as cant of occlusal plane. The more the angle, the more steep will be the occlusal plane. And the next important dental parameter of the Downs analysis is interincisal angle. We draw a line along the long axis of the maxillary central incisor and a line along the long axis of mandibular central incisor, and we find the angle between these two incisors, the inner angle between those two incisors. Angle of 135.4 degree is taken as an average value. The range is 130 to 150 degrees Celsius. The more less the angle is less than the mean, then the more proclined the teeth are. The more if the interincisal angle is more than average, it indicates the teeth are almost upright. If the interincisal angle is less than average, then it indicates the teeth are severely proclined or flayed. The next important dental parameter of Downs analysis is incisor to occlusal plane angle and incisor to mandibular plane angle. If we take incisor to occlusal plane angle, average value is 14.5 degree beyond 90 degree. That means 90 degree plus 14.5, 104.5 degree is the average value of incisor to occlusal plane according to Downs analysis. Any increase in this value indicates proclined lower incisors, whereas decrease in this value indicate retroclined lower incisors. Similarly, we have incisor to mandibular plane angle. The mandibular incisors should be 91.4 degrees according to Downs analysis. That means they should be upright on the mandibular plane. If the angle is more than 91.4 degree, then it indicates proclined lower incisors, whereas the angle less than 91.4 degree indicates retroclined lower incisors. Now, we draw a line along the APOG, point A to point Pogonion. Okay, this is called as AP plane, and then we find the protrusion of the upper and lower incisors with respect to this line. The upper incisor or lower incisor should be approximately 2.7 mm ahead of APOG line in a normal individual. If the upper or lower incisors are more than 2.7 mm ahead of the APOG line, then they are said to be protrusive. So these are the important dental and skeletal parameters according to Downs analysis, which is a very basic analysis that was initially proposed. Okay. Now, the next important analysis is Steiner's analysis. It was proposed by Cecil C. Steiner in the year 1930, and the reference planes are the reference plane which is used here is SN plane. In this analysis, we have skeletal parameters, dental parameters, as well as a soft tissue parameter. Let us look into one by one. So this is a SN plane which is taken as a reference plane according to Steiner's. Anterior limit of maxilla is, as I told you before, it is point A, whereas point B is the anterior limit of mandible. The first skeletal parameter according to Steiner's analysis is SNA. This is the angle between SN plane and a line drawn from nasion to point A. The average angle is 82 degree. Any SNA angle beyond 82 degree indicates that the maxilla skeletal base is more anteriorly positioned with respect to the anterior cranial base, or protrusive maxilla or prognathic maxilla. Similarly, we have a SNB angle. It's angle between SN plane and a line drawn from nasion to point B. The average angle is 82 degree. Here also, this angle relates the skeletal mandible to the anterior cranial base. If the SNB angle is more than 80 degree, it indicates prognathic mandible, whereas SNB angle of less than 80 degree indicates a retrognathic mandible or a class 2 skeletal pattern. The difference between SNA and SNB indicates the relationship between maxilla and mandible anteroposteriorly. The average angle is 2 degree. That indicates maxilla should be about 2 degree ahead of the mandible. If it is more than 2 degree, it indicates a class 2 intermaxillary skeletal relationship, whereas if the A and B angle less than 2 degree indicates a class 3 intermaxillary skeletal relationship. This is how the SNA relates maxilla to the anterior cranial base, SNB relates mandible to the anterior cranial base, whereas A and B relates the maxilla to the mandible. Now the next important parameter of Steiner's analysis is occlusal plane angle. It is the angle formed between the occlusal plane and the SN plane. The average angle is 14 degree. If the angle is more than 14 degree, it indicates more steep occlusal plane, whereas the angle less than 14 degree indicates almost the occlusal plane and the SN plane are in the nearly horizontal pattern. That means less steep occlusal plane. So the steepness of the occlusal plane is indicated by occlusal plane angle of Steiner's analysis. So those were the important skeletal parameters of the Steiner's analysis. Now let us look into the dental parameters. Here we draw a line along point N to point A. This is called as NA line, and we draw another line along the long axis of the upper incisor. Now we will see the upper angle between the NA line as well as long axis of upper incisor. For a given A and B of 2 degree, the upper incisor to NA angle should be 22 degree. This is the angular measurement. Whereas we also measure a distance from anterior or labialmost point on the upper incisor to the NA line. This is linear measurement and it should be 4 mm. Any angular measurement beyond 22 degree or any linear measurement beyond 4 mm indicates that the upper incisors are more protrusive with respect to the anterior limit of maxilla and anterior limit of anterior cranial base. This is the inference that we can draw from an angle between maxillary central incisor long axis and NA line. Similarly, we have the similar parameters for mandibular incisor to the NB line. We draw a line connecting the point N to the point B. This is called as NB line, and we draw another line along the long axis of lower incisor. Then we see the angle between these two lines, that is long axis of the lower incisor and NB line. For a given A and B of 2 degree, remember these values are for a given A and B of 2 degree. The lower incisor to NB angle should be 25 degree and the linear measurement from the labialmost point on the lower incisor and the NB line should be 4 mm, same as in maxillary arch. Any value beyond 25 degree or any value beyond 4 mm indicates that the lower incisors are severely proclined with respect to their mandibular apical base as well as anterior cranial base. Okay, so these two parameters, the NA to upper incisor to NA angular and linear measurements and lower incisor to NB angular and linear measurements, indicates the amount of proclination or retroclination or the amount of protrusion or retrusion of the maxillary and mandibular incisors with respect to their skeletal bases as well as with respect to the anterior cranial base. Okay. Now, one more dental parameter according to Steiner's analysis is interincisal angle, same as we see in Down's analysis. Here, we draw a line along the long axis of the upper incisor and one more line along the long axis of lower incisor, and we see the inside angle. The angle should be 130 degree on an average. If the angle is less than 130 degree, it indicates either the maxillary incisors are protrusive or the mandibular incisors are protrusive or both are protrusive. Whereas the interincisal angle more than 130 degree indicates either the upper incisor are retroclined or lower incisors are retroclined or upper and lower incisors both are retroclined, as you see in case of angles class 2 division 2 malocclusion. Okay. So that was about Steiner's analysis, the dental and skeletal parameters. Now, the next important analysis is a Tweed's analysis. It's nothing but, it's also called as diagnostic triangle. Here we have a FH plane, a mandibular plane which is tangent to the lower border of the mandible, and a line along the long axis of lower incisor, lower central incisor. So these three lines form a triangle. As we all know, the sum of angles of a triangle should be 180 degree. So also here, in a face which is supposed to be aesthetic, we need to have certain specific angulations between these planes according to Tweed's. Let us look into what are those angulations. The first one is Frankfurt's mandibular plane angle, or FMA. According to Tweed's, in a harmonious face, the Frankfurt mandibular plane angle should be 25 degree. Any angle beyond 25 degree indicates that the mandible is rotating in a clockwise direction. That means the patient is having a vertical growth pattern. If the FMA is less than 25 degree, it indicates the mandible is rotating in a counterclockwise direction and the patient is having a horizontal growth pattern. Now, coming to the second parameter of the Tweed's analysis, it is incisor mandibular plane angle. It's nothing but the angle between the mandibular plane and long axis of the incisors. According to Tweed, in a harmonious face, the lower incisors should be set upright on the mandibular plane. So, according to Tweed's analysis, the average angle is 90 degree. Any angle more than 90 degree of IMPA indicates proclined mandibular incisors, whereas any angle less than 90 degree indicates retroclined mandibular incisors with respect to the mandibular plane. Okay. Third parameter of Tweed's analysis is Frankfurt's mandibular incisor angle. This is angle between Frankfurt's horizontal plane and long axis of lower incisor. The average angle is 65 degree. If the angle is beyond 65 degree, it indicates the lower incisors are retroclined, whereas the angle is less than 65 degree, it indicates the lower incisors are retroclined. That means the variations in the angle and the outcome of the position of the incisor is quite opposite for IMPA and FMIA. You should note it down here. Okay. This is the Tweed's analysis, which gives you the specifications of the three parameters and how we need to adjust the relationship of the lower incisors as well as the mandibular plane with respect to each other in order to obtain a aesthetic and harmonious face. The next important basic analysis is Wits appraisal. Here in this analysis we have only a single parameter. This analysis is mainly introduced to know the anteroposterior skeletal relationship between maxilla and mandible. What we do here is we draw a line along the occlusal plane, and to this occlusal plane we will draw two perpendiculars, one passing through point A and one passing through point B. The point of intersection of each of these perpendiculars onto the occlusal plane is marked as AO and BO respectively. Now we will see the distance between AO and BO along the occlusal plane. Usually in females the AO and BO should in males the AO and BO should coincide. That means the difference between AO and BO should be 0 mm. Whereas in females, AO can be slightly ahead of BO by 1 mm, that is acceptable. As you all know that class 2 females are accepted, whereas class 2 males are not accepted, and similarly class 3 males are accepted, whereas class 2 males are not accepted. So if AO and BO coincides, or AO is slightly ahead of BO by 1 mm, then we can take the relationship as a skeletal class 1 relationship. On the other hand, if AO to BO is less than 0 degree, that is, if we get a minus value, that indicates the BO is more ahead of AO, which is an indication of skeletal class 3 relationship. Whereas if AO is much more ahead of BO beyond 1 mm, then it indicates that the maxillary and apical base, the maxillary anterior limit is more forward when compared to the mandibular anterior limit, which is an indication of skeletal class 2 relationship. Okay. Now, the Wits appraisal is largely dependent upon the changes in the occlusal plane. Okay. Any changes in the occlusal plane has an effect on the parameters of the Wits appraisal. This is one of the important drawbacks of Wits appraisal. Similarly, we have a drawback with Steiner's analysis also, because as the maxilla and mandibular grows, they will show some kind of rotational tendency, like upward and forward rotation or downward and backward rotation of the mandible and maxilla both. Now, the rotations of these jaw bases will also have the effect on the parameters in Steiner's analysis. So these are two drawbacks of Steiner's analysis as well as Wits appraisal, because Wits appraisal is under the influence of changes in the occlusal plane, whereas Steiner's analysis is under the influence of changes produced by the rotations of the maxillary and mandibular skeletal bases. These points you should note it down. Okay. So these are different basic analysis that we routinely use in our clinical practice, and these are the basic analysis that we need to understand at this point of time. Okay. As we know that any procedure has both merits as well as demerits, so also we have certain limitations for cephalometrics. Let us look into one by one. Cephalogram is a two-dimensional image of a three-dimensional object. That means we can analyze the parameters only in 2 dimensions of space. The third dimension is missing. That is one drawback of cephalometrics. Now, reliability is not always accurate. That means, if suppose I am tracing a lateral cephalogram and I am identifying a landmark, okay, these landmarks might not be reliable because I might not point it correctly, because the cephalometric analysis exclusively dependent upon how accurately we are pointing out the landmark. That means it comes with experience. The more the experience, the more we can rely accurately on the landmarks that are pointed by us. Okay. Now, in the cephalometric analysis, the growth pattern is not considered. Okay. That means there are no normative values for one type of growth pattern and there are no normative values for another type of growth pattern. For any growth pattern, the optimum or normal value ranges are same for every individual. Now, the mean values that we obtain on different analysis are proposed on different population. Its universal applicability is questionable, yet it's being used for all groups of population irrespective of their ethnicity. Okay, so their applicability universally to all groups of population is questionable, yet we are using this analysis in all groups of population irrespective of their ethnicity. Okay, now the form and functions of the various craniofacial skeletal structures are not taken into consideration according to different analysis that were proposed on the lateral cephalogram. Okay, so these are major limitations of the Steiner, of the cephalometrics and cephalometric analysis. Okay. Now, let us look into errors that are possible to encroach in cephalometry. We can classify the errors into 3 broad categories: radiographic projection errors, errors within the measuring system, and errors in landmark identification. Radiographic projection errors. What are the radiographic projection errors? As I told you, there are certain specifications for the positioning of the head in the cephalostat while taking the lateral cephalogram. For example, the lips should be in a relaxed position, the teeth should be in centric occlusion. Sometimes, and the eyes should be looking at the distant object at eye level with the FH plane parallel to the floor. If any of these things are missing, it will lead to errors in the cephalometry during projection. Okay. Similarly, we can also have radiograph distortions, magnifications. Okay. So these are different radiographic errors, projection errors that are possible with lateral cephalogram. So proper patient positioning and proper adjustments of the object film distance as well as object source distance will maximum eliminate the radiographic projection errors. Now, errors within the measuring system. Okay, so if we have during the radiographic analysis, if we find any problems, if we come across any problems during measurements that we make on the lateral cephalometric film, then we will land up into abnormal values which will add to an error in the cephalometric analysis. So we should be careful with the measuring systems that we use during cephalometric analysis. Okay. Now the next important error is errors in landmark identification. This is the common error that we find in a newcomer. So exact knowledge about the anatomical landmarks as well as derived landmarks and different planes is very much essential prior to you sit with lateral cephalometric analysis and cephalometric tracings. Okay, so you should have a good knowledge pertaining to different landmarks and planes that are used in lateral cephalogram. You should be thoroughly trained in these aspects so that you will land up in minimum mistakes or minimum errors in your entire process of cephalometric tracing and analysis. Okay, so these are errors in cephalometry and the processes of how to overcome these errors in a brief manner. So this is about the lateral cephalometric analysis and the knowledge which you should have about this topic at this for this point of time. Hope you all understood. Thank you.